It's our pleasure to have Dr. Yi and our own Andrew Schroeder kind of give you an update on some of what we're doing, learning, and thinking about here at Direct Relief. Very briefly, I think the role that Direct Relief plays as a private charitable organization is as a medical supplier for public benefit reasons. We work in all 50 states. We have a unique accreditation to provide prescription drugs in all 50 states. It's always free of charge. We also work in about 100 countries each year around the world, trying to provide items that we can get through donation that are unavailable to patients who need but can't afford them in low-income countries and during emergencies. So in connection with the coronavirus, for the past 7 weeks, beginning on as of Monday, Direct Relief has been really active in China, unexpectedly and a total surprise to us, having been asked for what we believed at the time was a relatively strong stockpile of personal protective equipment. Masks, gowns, gloves, goggles, the types of things that we stockpile here in the event of an outbreak. We were asked, unusually for us, by the officials in China, including the hospital director at the Wuhan Union Hospital, you know, the largest hospital in Wuhan, that the kind of ground zero for the outbreak. We understood how important this would be to get in front of it as best we could. So of course we provided what we could. We were fortunate that we work closely with FedEx, which has a large footprint in China with 8,000 employees. You know, we were able to tap our stocks, arrange the logistics, and provide for us a significant volume of personal protective equipment for the Chinese folks who were clearly hit hard by it early on. Since that time, it turned into about 30 or 40 shipments to more than 40 facilities, thousands and thousands of surgical masks, N95 masks that we actually manufacture in China, as well as gowns and gloves. It became clear early on that we wouldn't be able to fulfill the full set of needs with our stocks for PPE, and we knew also that we should reserve some in the event that the virus arrived here in the States, which it since has. But with the benefit or burden of having worked in China for the past 7 weeks and seeing how the spread has played out, it's been instructive. Unfortunately, you know, what China's being caught short with their PPE that required outside support created a global shortage everywhere for the personal protective equipment. That presents a series of challenges just for the outset and how we can deal with the outbreak here. Dr. Yi can explain why we think it's so important here at Direct Relief to make sure that the safety net facilities, of which there are thousands, 12,000 in the United States, are really a critical element to this whole approach nationally. From Direct Relief's perspective, it's been a very government-centric view of how these events are unfolding. Obviously so, the public health officials, it's their job to manage, but we recognize how important it is to mobilize private resources and channel them productively and efficiently in coordination with those public health officials, which Direct Relief does all the time. We're doing it in California. And we suspect that the need for that more mobilization of resources put at the problem as best we can will help reduce the impacts on health in the larger society. So I think today what we're going to do is have our own Dr. Andrew Schroeder report a national survey about the state of readiness, some issues around the personal protective equipment at these this large safety net of the community health centers in the United States that serve as the front line in almost every emergency and often unrecognized as such. Our experience is that with the 29 million patients that they serve on a day-to-day basis, many of those patients meet the profile of social vulnerability. They tend to be lower income. They tend not to have other resources. They rely heavily on this as their medical home and point of care. And they're, in a sense, vulnerable on a good day and particularly vulnerable on a bad day when these emergencies happen. So that's why Direct Relief leans in so heavily, supporting with private resources the public benefit and public health efforts and day-to-day clinical work of the community health centers. The other thing I'd note just at the outset is that the focus appropriately is on the protection and the prevention of transmission. what is possible to do to reduce the number of cases, with the expectation that 5% of whatever that number is are likely to end up in an ICU. So we're doing two things at Direct Relief. We're stepping up our general support to the health centers and free and charitable clinics around the country. We've boosted by 50% since January our day-to-day deliveries of medications for chronic illness, because we're concerned about the people who rely on health centers for their medications as well as their care. There's been 4,800 deliveries from Direct Relief since January to community health centers in the United States. It's a 50% increase in our support to the safety net health centers in this country. At the same time, we're looking at the potential for shortages that might exist, like PPE. Projecting forward what happened in China, it's very difficult to get in front of the PPE shortage issue right now. Money won't solve that soon. However, we're on the front end of the wave, and I think if we look at what other things are likely to get pressurized and potentially cause shortages, ICU medications are one of them. So Direct Relief has spent the past few weeks developing an estimating tool to run those scenarios, to mobilize resources that are suitable for care of people who end up in the intensive care units, and really start coordinating to make those provisions available. Very thankfully, Pfizer and others that we work with routinely have come through, agreed to support that, to have a backstop for that potential spike in ICU patients. And that's an unusual role for Direct Relief to play, but we are in unusual times. So finally, I think the importance of supporting the health centers during this time. There's a lot of chronic disease in the United States, and the health centers do a terrific job of helping people manage things like diabetes and hypertension and asthma. If that is not well managed because of the redirection of resources to the coronavirus, we have played that out, and you can assume that unmanaged chronic disease end up being acute cases that require hospital care. So we can't emphasize strongly enough how important the two-track approach is to boost support to the health center to maintain the important management of chronic disease, while also directing thoughtfully resources to both contain and prevent the transmission as best we can of the virus. Much of it will depend on individual action and the social interventions that are going to be critical for personal hygiene and social distancing, and also then looking at how we can bolster the potential for spike in ICU patients around this country. And some of those scenarios are quite sobering. With that, I'll turn it over to our Dr. Andrew Schroeder, can talk about the survey, the national survey that we just completed, and he'll give you a brief on that. Thank you.
All right, so thanks, Thomas. And like Thomas just mentioned, Direct Relief supports a pretty extensive network of safety net health centers across the country. And one of the first things we started to think about when we were trying to plan for the scope and the form of the response that this would have to require, we decided to reach out to our network and just understand where they're at, what they're worried about, what they're ready for, and issues that we need to flag, ranging from supply to a range of other questions, including planning and including the types of other concerns that their patients have beyond just the impact of COVID-19. So this survey was conducted starting March 4th. We closed it March 9th. And so it's a snapshot in time from that period. And so understand it in that context. We surveyed 1,400 health centers, and we got 612 unique responses back from basically all areas of the country, 47 states, plus DC, Puerto Rico, and the US Virgin Islands. So it's a pretty good sample of what people are responding to across the country. And we can summarize and make this available to people that are interested in understanding some of these dynamics at a later point. The network that we surveyed represents a total of 56,454 total staff with patient contacts. One thing to note about this network is it's a highly variable network of types of institutions. So some of them are quite large, quite sophisticated, urban health networks, with quite a large staff, and some of them are quite small, and they're more rural, and some of them are free clinics, and some of them are federally qualified health centers, which are qualified through the U.S. government to receive Medicare and Medicaid payments. So it's a spectrum of a lot of different institutions that treat the most vulnerable. We surveyed them on really three kind of categories. The first is on sentiment, basically how concerned they are about different dimensions of the impact of coronavirus, their preparedness and planning. So how prepared are they? Do they feel, and what kinds of plans do they have in place? Where are some of the gaps? And then really specifically around personal protective equipment and how much they use, where their confidence is around resupply, and other kinds of specific issues around that I think have been really in the news a lot lately around how we make sure that the health workforce, especially the health workforce that's dealing with some of the most vulnerable people, is going to be able to prevent infection and maintain continuity of operations. So in terms of sentiment, I think the high level message is that people are very concerned, and they're concerned about they're more concerned the closer you get to their operational status. So obviously there's a lot of folks here that are very concerned about the negative health impact from coronavirus on their patients. But as we go into the likelihood that COVID-19 will disrupt their daily operations, that includes quarantine, that includes other public service stoppages that might disrupt their capacity to operate, they grow more concerned. And by the time we get to the specific question of the likelihood of a surge of patients coming into their doors, which is actually quite similar to some degree with the added dimension of enhanced infection control measures, they're the most concerned about the capacity to handle a surge of patients. And I think this has implications that are worth talking through around how we message, where people should go, how they can get care, and kind of what the most appropriate places are to kind of receive the kind of appropriate medical response to COVID-19. We don't want health centers to become overwhelmed and to, themselves become sites of viral transmission in the more extreme cases. And this is clearly flagged at a high level by health center personnel across the country. We asked them a lot about, epidemic response and then specific COVID response planning. So, this is something that health centers have been through before in the past. I would say the closest analogy was the H1N1 epidemic, which was some years ago now. And prior to that, the SARS epidemic for folks that are not in the United States. Epidemic response planning is at different levels of development throughout the network. So, it was at 42% of the network reported they have a epidemic response plan in place already, and they have activated it. And a higher percentage is either does not have such a plan or is in development. And those numbers get larger when you talk about specific COVID-19 response plans. So I think there's a role that is worth kind of figuring out around how we can most effectively get health centers with plans in place for what they need to do to respond to the epidemic, and specifically how to manage through the COVID-19. The communications issues were of concern to us, particularly around how health centers communicate with patients that may be self-isolating and may have a kind of range of other needs and may need quick information as a very dynamic situation may change in their local area. this is also, I think, similar to what we would kind of need to understand around any natural disaster, but again, with some enhanced efforts around the kind of messaging that needs to take place here. Communications plans are also really in need of development, although many places that work is well underway, and the kinds of things that people are doing, developing phone trees in the most sophisticated systems. They have EMRs that are automating alerts to phone and text. They have dedicated SMS alert systems that have been built often for natural disaster response, and then just things as simple as email around to staff and patients. I do think there's a lot of room here for being able to build capacity for strong communications networks between health centers and patient communities, especially as patients are self-isolating and may need additional social supports throughout this whole time period. We asked them about testing. So although testing shortages have been kind of a broader conversation and we don't really have any information about availability of tests specifically, we were trying to figure out if testing was available, would health centers be able to administer them? Did they feel confident in being able to play a role in that regard? And I think the answer was pretty resoundingly yes, although some had more reservations than others. And there's a worthwhile conversation to be had here about where we could have health centers, as testing becomes more available, play a significant role in being able to expand those networks out, particularly to the most vulnerable patients. However, there is a lot of concern among the health centers about the potential for closure of operations. A little less than a third were very seriously concerned about potential closure, but a number were uncertain. When people were asked about the reasons why they were most concerned, their most kind of repeated concerns focused in on the possibility their staff may be quarantined or self-isolated, and that PPE shortages may prevent them from protecting their staffs to the level that they felt was acceptable for being able to continue with even regular health center operations, which led us into questions around personal protective equipment in particular. So looking out at whether or not health centers have reliable sources of resupply over the next 1 to 2 months, the overwhelming answer there is no. Or they are uncertain. There was a lot of concern echoed back to us that although they may have some stock on hand, that they are being told regularly that their normal vendors for PPE are themselves stocked out and have not given a reliable answer as to when they would be able to purchase again. And so this kind of shortfall seems to be something that is echoed as a significant concern throughout the health center network. And bearing in mind that health centers do not normally deal with this kind of none of us do, this large-scale epidemic outbreak that might include expanding who has to use PPE if they have patient contacts. Were training plans in place for safe usage? About 2/3 have those training plans in place, but as you can see, a number are actually having to add into their training plans how to get their staff much more well-versed in just basically how to safely put on and take off PPE without actually risking infection. We saw this extensively in West Africa, for example, during the Ebola outbreak, that even aside from the supply questions, making sure that people know how to operate PPE in a safe way was one of the most important kind of pieces of information that needed to be passed along. Just really quick, the most common types of PPE that health centers tend to have are not things like N95 masks and not face shields and other kinds of things like that. It's surgical masks and latex gloves. And in many cases, people actually reported to us that the most likely area of their facility that would have PPE of any kind was their dental group, not their kind of main staff. And this I think is significant to think about when we look at who these health centers are. They may actually not use PPE to a great extent in many of their, normal, preventive medicine, things like that doesn't necessarily require this kind of equipment. So the supplies on hand actually tend to be relatively small. And so the distance between where they are now and where they might be if they had to dramatically increase usage would be actually pretty narrow. So I think there isn't a lot of wiggle room in that system. And that actually is correlated with places that tend to be larger and more sophisticated. So where you tend to get much more utilization and have a much more diverse array of material on hand, including more likelihood of having things like N95 masks, which we've heard a lot about since, as Thomas was mentioning, the response in China, where the N95 mask became kind of the primary symbol for being able to protect yourself. The likelihood of access goes up dramatically as you increase the size of the staff, which tends to reflect that they are more likely to be urban systems that are providing a more diverse array of services, as opposed to more small and more rural clinics. And as the geography may change over time, it's worth really bearing that in mind in terms of what people actually may have or not have in their existing inventory. Just a couple of quotes I thought were worth flagging from people that, from the Missoula Urban Indian Health Center, that they are, specifically worried about back-ordered medical supplies and their staff becoming infected. From Korean Community Services in Buena Park, that their all-consuming need right now is PPE, and they're worried about being able to continue operations. And then from Dr. Gary Bernstein Community Health Clinic in Pontiac, Michigan, that they're concerned about what happens with their other patients, as Thomas was saying earlier, diabetic and hypertensive patients, if they may have to close temporarily because of some of these infection control issues. These are health centers that deal with many of the most serious multi-chronic conditions among patients, and there is a lot of concern about what the long tail of some of these kinds of effects would be. Just a couple of final additional concerns to flag that kind of came up as we sort of asked people about what they were most concerned about. Just four I'd like to name, and we can talk more about them. One is volunteers in the health system. The second is homelessness, the impacts on staff and other social vulnerabilities that staff at health centers have, and then the patient's financial challenges, especially as they think about questions of self-isolation that might be required in order to stem the tide of the illness. On volunteers, especially for smaller health centers, that they have a large number of services being provided on a volunteer basis, and volunteers may or may not have the ability to come in anymore, particularly with lacking adequate supplies. And this was flagged by several people, kind of even above and beyond just their regular staff. Homelessness is a very, very significant issue beyond the kind of conditions that homeless people may be in, which already are high risk for viral transmission of other kinds, hepatitis C being a good example. The people that are serving those communities and are really attempting to make sure that their own staff that conduct outreach in the homeless communities are able to remain protected while they are doing this work. I think that's a really significant issue. It's worth bearing in mind that staff themselves are in a vulnerable position often. In North Mississippi, primary healthcare from Ashland, Mississippi, they really emphasize that their providers and nurses that have school-age children may not have access to childcare, and how they make sure that continuity of operations continues in the absence of things like childcare for staff is a very high-level concern for them. So what are the other social supports that are required not only for patients, but really centrally for the staff themselves? And then finally, that we're talking about some of the most vulnerable people in the country, and they have a wide variety of financial challenges, as well as a wide variety of health issues. food insecurity, and other questions around precarious work, and what they are going to be facing if they are not able to work for any length of time, and may need to manage other conditions, is something that there's a lot of active discussion around, a lot of concern around, and I think something that we can all come together around as a way to help mitigate some of the impacts of these on people that are served through the health center network. And so with that, I will turn it over to Paul and to Dr. Yee. Thank you.
First of all, I want to thank Thomas and Direct Relief. We've been partners for years, and we've been the ones partnering with you all and other federal agencies to be on the front lines as some of the first responders. You saw this with the California fires, hurricanes down in responding in Texas and Florida, Puerto Rico. So I appreciate your support, and it's these kind of collaborations that really have an impact on some of the most needy populations. As Thomas has mentioned, the health centers have 12,000 sites over every single state, territory, District of Columbia, and Puerto Rico. And so we play a critical role on the front lines. And it was mentioned, I think it's critical more so in these pandemics. And as we saw in H1N1 in 2009, the health centers played a really key role. So I think there's three things that really, I think, underscore why this relationship is so critical. Is number one, health centers are uniquely positioned, as we mentioned, all over the country. In some of the poorest areas and rural areas of our country, we are so uniquely placed. We have a great staff ready to go. We have 230,000 employees, including 27,000 clinicians and 80,000 nurses, medical assistants, pharmacy, lab, and x-ray. They are all over the United States. And should we need to do, say, mass immunizations, we have a staff that's already trained. When I was on the emergency response in California, when I practiced in California for 20 years with farm workers, we were right in the middle of the emergency response for Fresno County and for the state. And they looked to us to be the ones to go out and do mass immunizations. If we needed antivirals in a mass distribution, health centers have pharmacies that are ready to go. So that's the first one, is we are uniquely positioned and staffed. Second of all, we have established relationships. Our patients follow us because we do primary care. Health centers have been around for 55 years. And so we have these very strong and trusting relationships with our patients. So when something happens, like a disaster, they come to us. They call us, they show up, they ask us, and they trust us. These are family members of people that work with us, and we go for generations. So I think it's critical, as Thomas mentioned, we understand our populations also, all the cultural, linguistic factors, social determinants of health, all those socioeconomic factors that really influence people's ability to access and understand what to do in these situations. So I think it's really critical that we do that. And third, I think it's really important to look at the existing infrastructure that health centers have. We have all those sites out there, but also with those sites, we have the backing of HRSA and the Bureau of Primary Health Care. Jim McCrae is right alongside us on the 330 Public Health Service grants. And really, this is what really glues us together, is we have a basis to start from. Along with that, we have over 50 primary care associations in each state. And so those are ones that help organize health centers on a state basis. You drill down a little bit further, and we have our health center networks that really focus on information technology, electronic health records, and organizing all the data and data analytics that are necessary. So these over 80 networks will work together. And I think, Thomas, you brought out, and I think also Andrew, as you mentioned in your data and studies, we need a coordinated response. We have the infrastructure there. We need some funds and support from Congress to really link all of these together. And I think along with Direct Relief, we can appropriately figure out where do those supplies need to be distributed. If nothing's happening in a certain part of the country, we can take those supplies and whatever we have, we can shift them to California, to Seattle, Washington, wherever we need it, and then keep track of it. So I think that's the bigger picture of what we want to do and why the health centers are so critical. So I think those three things are the unique positioning, our established relationships, and then existing infrastructure, along with our partners. We work at the Bureau of Primary Health Care, the CDC, NIH, SAMHSA, all these different ones, HIV/AIDS Bureau, we're together, but we need something to pull us together. So at NAC, as you saw from Andrew's data, is we really need to do some heavy duty education. Health centers are required to have these emergency operations plans in place. as he mentioned, they have them, but they're about 40 to 50% of them have something that's really active. So we need to do some heavy duty education to bring that other percentage up to really be a functioning level. So I think overall, we are positioned right. We have great relationships with our patients and partners locally. And then we also have that infrastructure to really move in a brisk manner and very coordinated and have big impact. So I think for me, I think that's why the health centers are critical and why Direct Relief is such a great partner to be able to get those necessary supplies and medications. Right now, we don't have specific medications for coronavirus, but we do need those supportive medications to bring down the fever, to get the cough and cold under control. So I think working together, it's critical. I want to end with, it's really critical, and I hope Congress gets this message too, that the health center funding is on the borderline right now. May 22nd, that is going to run out, and that will severely impact us being able to respond. 70% of the grant funding would be gone. And so you talk about thinking about closing, and that's going to be a direct reason to close, not because we're overwhelmed or we're in surge mode, but we really need that funding that goes out May 22nd, along with teaching health centers and the National Health Service Corps. That's where we get our workforce. So I think those things are critical. I hope Congress gets that message and knows that we are on the front lines ready to go. We need to do some training and catch up on a few things. But if we have the proper equipment and funding, we can be right on the front lines, which we are.